Hello everyone, welcome to the literary and jury charge portion of the 100 class. We're going to start off with some Latin and French words. I will give you the words and then I will read the paragraph. Okay, we have actio in rem, si pre, latches, and pro forma. Okay, here's your paragraph. Actio in rem is an action brought against a thing. Actio in rem is usually an action against property. Si pre is a French term meaning as near as or as close as possible. The court, using the si pre doctrine, tries to carry out the express wishes of the deceased. Latches is a French term meaning a failure to do the proper thing at the proper time, when there is an undue delay in the plaintiff asserting a claim. The term latches is applicable. The si pre doctrine generally deals with trust. Latches may place an undue or unreasonable disadvantage on one party. Pro forma means to do things in a certain way. Pro forma means for the sake of or as a matter of form. Okay. I've got a fun little article here. This is on public lives. Whatever happened to? Here we go. Ready? Whatever happened to Tanya Harding is one of the most famous figure skaters ever. Less for her skating than for her role in a conspiracy to injure her rival, Nancy Kerrigan, just before the 1994 Winter Olympics. Nevertheless, Kerrigan won the silver medal and Harding finished 8th. Harding became a tabloid fixture, mired in domestic disputes, leaked sex tapes, and a televised boxing match with fellow tabloid fixture Paula Jones. In 1996, she starred in her only film role, a direct-to-video crime drama called Breakaway, about a drug mule who wants to retire after one last job. Harding plays Gina, one of the mule's accomplices. And a mule is just a person who transports drugs, like concealing them in some body cavity. That is what a mule is. Interesting. All right, going on to some medical. We're going to do a continuation of this Harvard Heart Letter. Okay. And we are on who feels what and why. Here we go. Are patients with ischemic heart disease who do not experience chest discomfort or an angina equivalent simply less sensitive to pain than most people, although in some studies a higher pain threshold has been associated with advanced age or diabetes, the data are not. Other research has suggested that only prolonged or severe episodes of ischemia cause angina and that milder spells are too brief to cause symptoms. When patients undergo balloon angioplasty to open narrowed coronary arteries, these vessels are completely occluded for a brief period. During these physician-induced episodes of ischemia, cardiologists have found that chest discomfort develops only after the lack of oxygen has caused several other changes. As soon as part of the heart becomes ischemic, its muscle cells lose some of their strength and contractions are less forceful. In addition, the ischemic region becomes stiff, so the heart does not fill as well with blood during its relaxation phase. The result of these changes is that with each contraction, the amount of blood pumped by the heart decreases. Fluid may then accumulate in the lungs, causing congestion and shortness of breath. If the ischemia persists for 10 to 20 seconds, part of the ECG called the ST segment may fall below the usual flat baseline. Angina usually occurs only after several additional seconds of ischemia. If an episode of ischemia abates before angina develops, the patient may never experience this symptom. The duration of an ischemic episode before the onset of chest discomfort varies from person to person. Exercise tests, the key means of detecting silent ischemia, have shown that people whose angina developed more than 1 minute after the onset of ECG changes tended to have a higher proportion of asymptomatic versus symptomatic episodes of silent ischemia. Valuable warning signs. Since asymptomatic episodes tend to be more short-lived and less severe than angina-producing ischemia, are they important? Available data indicates that the answer is yes. According to several reports, patients who have evidence of ischemia during ambulatory ECG monitoring or exercise testing, but have no symptoms, are at higher risk for heart problems, such as a future heart attack, than are those who have no ischemia. For example, one study found that asymptomatic middle-aged men with 2 or more risk factors for coronary disease were more than 3 times as likely to have heart complications if ischemia was detected during exercise testing. Other investigations have shown that the prognosis is worse in heart attack survivors and patients who undergo peripheral vascular surgery, operations on the leg arteries, if the patient has silent ischemia. No one should be too surprised that ischemia, whether silent or symptomatic, increases a person's risk for a heart attack. However, angina should not be viewed as a curse that some fortunate people escape because they have higher thresholds for pain. In fact, most cardiologists feel that this warning sign is useful in that it prevents patients from exerting themselves beyond the point at which ischemia ensues. Without the symptom, people might continue to walk up a hill or engage in strenuous exercise despite the stress imposed on the heart, whereas individuals who experience angina could stop, rest, and take a nitroglycerin tablet for relief. Should silent ischemia be treated? Medications prescribed to treat angina are also effective in preventing silent ischemia and include beta blockers such as propanol, metoprolol, calcium channel blockers, and nitrates. If medical therapy is not successful, bypass graft surgery or balloon angioplasty can be used to treat asymptomatic coronary disease. The burning issue, however, is whether silent ischemia should be treated. Since there are no symptoms to be relieved, treatment cannot make someone feel better. In fact, anti-anginal medications may make patients feel worse by causing severe side effects or constantly reminding them of their condition. So far, no one knows whether the use of drugs to eradicate asymptomatic ischemia actually improves survival. When the presence of angina is used to guide conventional treatment of coronary disease, annual survival is about 97%. Even for patients who have had a heart attack, whether more medications can improve upon this excellent rate is far from certain. The National Institutes of Health is sponsoring the first phase of a major investigation, the asymptomatic cardiac ischemia pilot study, to assess whether treatment of silent ischemia is beneficial and can prevent heart attacks and deaths from coronary disease. Most experts argue against routine ambulatory monitoring to screen healthy people for silent ischemia, since the condition might be falsely diagnosed in many people without coronary disease. The patients would be needlessly alarmed and possibly subjected to the risks and inconvenience of further testing and treatment. For similar reasons, ambulatory ischemia monitors should not be used initially when the physician is trying to confirm a diagnosis of angina. The exercise test is more effective. More controversial is the issue of whether patients with known coronary disease should be evaluated for the presence of silent ischemia. Patients who have had a heart attack have an increased risk of further complications. However, in a study of patients with stable angina directed by Dr. Peter Stone of Brigham and Women's Hospital and Harvard Medical School treatment of ischemia detected by ambulatory ECG monitors did not decrease symptoms or improve exercise capacity, since at this time there is no evidence that symptoms or survival can be improved by treatment. Arguments in support of increasing medication doses to eliminate ECG changes are not compelling. In summary, silent ischemia should be considered a warning sign in special situations, such as after a heart attack or before surgical procedures, but the value of screening in most patients with known or suspected coronary artery disease is not clear. Ongoing research may reveal when this problem is important and when it is not. In the meantime, the diagnosis and treatment of ischemic heart disease should be based predominantly upon the frequency and severity of angina. All right. I know that was a little long, but it's great for your endurance. All right. And some of these words, we said ischemia several times. Let's see here. Let's see. Some of these other, I know I've covered a couple of these. Propranolol. That was another one. Propranolol. Propranolol. Let's see. I think we heard metoprolol. That was another one. Metoprolol. 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 I think that's it. Asymptomatic. So again, add those to your dictionary after class. So it's a good time to do that. All right. So I'm going to read some jury charge. This is general jury charge. All right. Here we go. Discrepancies in a witness's testimony or between his testimony and that of others, if there was any, do not necessarily mean that the witness should be discredited. Failure of recollection is a common experience, and innocent misrecollection is not uncommon. Also, it is a fact that two persons witnessing an incident or a transaction often will see or hear it differently. Whether a discrepancy pertains to a fact of importance or only to a trivial detail should be considered in weighing its significance. You are not bound to decide in conformity with the testimony of a number of witnesses that does not produce conviction in your mind as against the testimony of a lesser number or other evidence that appeals to your mind with more convincing force. This does not mean that you are at liberty to disregard the testimony of the greater number of witnesses merely from caprice or prejudice, or from a desire to favor one side as against another. It does mean that you are not to decide an issue by the simple process of counting the number of witnesses who have testified on the opposing sides. It means that the final test is not in the relative number of witnesses, but in the relative convincing force of the evidence. Remember that you are not bound to decide any question of fact according to the testimony of a large number of witnesses as against a lesser number of witnesses when such evidence does not produce conviction in your mind. The test to be given to testimony is not merely the number of witnesses, but rather the weight to which the testimony of such witness or witnesses is entitled. Now, in that particular segment of the jury charge, I said that you are. That came up twice. That you are. You can phrase that whole thing. THAUR. And then back to the medical. I know that was more challenging. I read the jury charge at 100, but the medical I read at 80, and I know that is a lot. It's a lot more difficult to write. The material is more dense, but if you come across a word, you hear a word you're not sure of, you don't know what it is, just write it out phonetically. And if that were a test, you would go back and you would look it up and change it. So that's why, it's so important that you don't get frazzled when you hear maybe a medical word or a legal word that you're not sure of. Just write it out phonetically. So that's all we can do. And then you go back and look it up in the dictionary. Okay, so that concludes our literary and jury charge for the 100 class. Have a great day.